Many times with an older population, the assumption is that, of course, you should be depressed. I've lost my spouse, I've lost my independence, I have physical problems, of course I should be depressed. And my response to that is, while you're here, you might as well have the best quality of life you can have. So yes, we should definitely treat the depression. People die from severe depression. I've had patients that have died because the depression has reached the point where it's been so severe that they end up lying in bed, they don't eat, they get dehydrated, and the snowball effect starts with geriatrics.
The GDS screening in this video is used with a resident living in her own apartment in a continuous care facility. The resident had been visited previously by nursing students from a nearby community college. The students and their instructor have returned together to visit based on the students' concerns about the resident's overall mood and comments. Please note that the resident prefers to be addressed by her first name. You will also notice that after the screening is completed, several follow-up questions are asked. These questions are not on the screening form, but are based on the critical thinking of the practitioner performing the GDS screening, and are designed to obtain additional information that can guide initial recommendations for care. I'm one of the nursing faculty at Community College of Philadelphia, and I think you met Venus and Rachel last week while they did their clinical rotation. When we first came in, that students had some concerns that you had verbalized to them about how you were feeling last week. And I wanted to just ask you a few more questions about your spirits, if that's okay.
That's fine.
Okay. Do you feel like you're basically satisfied with your life?
I think so.
Okay. Have you dropped interest, have you lost interest in activities that you used to enjoy?
Sometimes, yes.
Sheila, do you feel like your life is empty?
Yes, at times I do.
Okay. Do you often get bored?
Yes.
Sheila, do you feel like you're in good spirits most of the time?
No, I don't.
Okay.
Particularly earlier in the day.
Okay.
And morning used to be the good time for me, and it's not anymore.
Are you afraid that something bad is going to happen to you?
A couple of months ago I was.
Okay.
But I don't feel that way today.
Okay. What did you think was going to happen?
Perhaps if somebody I knew was going to die.
Okay.
Or get seriously ill.
Right. Do you feel like you're happy most of the time?
Not really. I may put it on a good front, but I'm really not that happy.
Do you often feel helpless?
No, I don't.
Do you prefer to stay home rather than going out and trying new things?
Depends what the new things are.
Okay. And do you feel like you have the energy or the interest in going out and trying something else, or do you feel like you would just rather stay home?
I think I'd rather stay home.
Okay. Do you feel like you have more problems than most people your age in terms of your memory?
No.
Okay. Do you think it's wonderful to be alive right now?
For the most part, yes.
Okay. Do you feel pretty worthless the way you are right now?
Occasionally.
Okay. Like in the past week, how?
Yeah, there have been times when I felt.
Do you feel like you're full of energy?
Not really.
Okay. Do you feel like your situation is hopeless?
Yes. I don't want to be a burden on other members of my family.
Okay. Do you think that you're better off? Do you think that most other people are better off than you are?
No, I don't.
Okay.
No.
After asking the 15 screening questions, Lorene goes on to ask a few additional questions based on the results of the screening. These questions help her explore some potential ways to treat the depression.
Sheila, what have you done? What do you do that makes you feel better? What helps you feel better in terms of your spirits?
I think it helps to get out
Okay.
and get out of the apartment, and maybe a pleasant apartment, but there aren't anybody else here, so it's necessary to meet people for meals and chat, or go to the short story club. We have similar interests in reading and discussing what we read.
Right. And do you find that you have the energy to pursue those things?
Some days I do, and some days I don't.
How would you describe your mood?
Today, well, today it's good.
Okay. Like in the past week, how would you describe your mood?
Some days have been good and some days have been bad, up and down. I think that because we've had hot weather, that's had some effect.
Right.
On
Because
my
you can't
mood.
go out as much.
That's right. That's right.
Do you feel depressed?
Sometimes, yes.
Can you remember a time in your life that you have had trouble with depression?
Yes.
More than one period of time in your life?
Probably about, I'm trying to think, maybe 20 years ago.
Okay. And were you treated then?
Yes, I was.
Okay. With medication?
Yes, medication.
If you could make two things better in your life, what would those two things be?
Oh my, what a question. Oh dear.
If you could identify even one thing that
Even
would
one
improve
thing.
your quality of life, what would that be?
Probably being more with people and less.
More with people.
Mm-hmm.
Do you ever have thoughts that you would be better off if you weren't living?
Occasionally.
Okay.
Occasionally.
Ever think about having any plan that you would harm yourself?
20 years ago when I suffered from depression, I can remember thinking it would be nice to stick my head in the oven.
Okay. How about now?
No. I think somebody talked me out of it 20 years ago.
Do you have somebody that you talk with in terms of your mood and when you feel low?
Yes.
Okay. A family member or a friend?
I have a spiritual friend that I talk to.
Do you talk with your primary care provider about how you're feeling in terms of your spirits?
Yes.
And what have they said to you? Have they talked to you about any treatments?
They have mentioned that perhaps antidepressants might help. Yes.
But you're not on any medications right now?
Not right now.
Not right
We're
now.
just waiting.
Right. And you continue to have the symptoms. And you had them, you said, for a couple of months.
That's right.
Right. So that's a long time to feel
it is.
not so good.
It certainly is.
Sheila, some of the symptoms that you described can be consistent with a depression. And we will talk with your doctor. And one of the options is medication and talking therapy. Would you be amenable to treatment for the depression if we find that this is in fact a full-blown depression?
That really might be of some help.
Right.
Yes.
It could help with your quality of life. Right.
I think so.
Depression is a medical diagnosis that encompasses many different symptoms, including concentration, interest, sleep, appetite, mood, subjective mood, irritability, interest in activities that one used to enjoy. And there's a range of symptoms.
The gold standard for diagnosis of depression is the Diagnostic and Statistical Manual of Mental Disorders, and they list 9 criteria for depression. 2 out of the 9 must be present for any diagnosis of depression, minor or major, and they are depressed mood and loss of interest or pleasure in activities that used to be pleasurable. To be characterized as having a major depressive episode, you need to have 5 out of those 9 symptoms present over a 2-week period of time consistently, and also representing a change from baseline usual functioning. To have more of a minor depression diagnosis, it's usually it's the same 9 criteria, but usually it's less than the 5 but also present for the 2-week period of time and having a change in function. It is not normal to be depressed when you're old. It is quite prevalent and common, and hence people sometimes think that it's a normal part of aging, but it is not a normal part of aging. Depression is quite prevalent among older adults. Approximately 15% of those over 65 suffer from depression, often undiagnosed and untreated. Long-term care being the most prevalent, ranging anywhere from 16 to 30%, depending on which study you're looking. I've even seen as high as 43%. In outpatient care, the prevalence is approximately 10%. In acute care, the prevalence is about 23%. The Geriatric Depression Scale is a screening tool for depression that was initially developed in 1983 by 2 researchers, Yesavage and Sheikh, so it's often known as the Yesavage Geriatric Depression Scale. It is a screening tool. It is not a diagnostic tool. The initial tool in 1983 was a 30-item yes-no questionnaire. It has since been shortened in 1986 to be a 15-item yes-no questionnaire. One of the benefits of using the short form is that it only takes approximately 5, maximum 7 minutes to complete.
Well, sometimes with the GDS, when you're asking the questions, some people want to expand on the answers, which is perfectly normal when you're asked some of those questions. So one of the challenges is just kind of redirecting people constantly back to the tool. Some of the other issues that come up sometimes are people who are so depressed and withdrawn that they don't want to answer the questions, or they're not able to answer the questions because of the depression. They have to be coaxed to answer them. I think it's really important when we're doing that. So one of the things that increases the ease in administering the test is developing somewhat of a relationship with the patient. The cultural considerations that usually arise are with some people who don't feel comfortable answering what they consider personal questions. What I might consider to be a personal question, somebody else might not consider that to be a personal question. So I think we always need to be aware of that. Other cultural considerations with the geriatric population are that depression might be perceived as a weakness. So I don't use the word depression. I never go in and say, I'm going to do a depression screening on you. I'm going to use a depression tool. I will start with saying things about, I'm concerned about your spirits. You said that you were feeling blue. Let's talk a little bit more about that. I find that unless the patient brings up the word depression, that word can be a barrier at times. We've evaluated Sheila this morning. I wondered, Rachel and Venus, if you had any questions after the talk that we had with her about her spirits.
I had a question. How often should a healthcare provider assess for depression?
Generally, they should assess for depression with an initial contact, an initial assessment on the person, and then yearly, especially with geriatrics, and then also if there's any suspicion that some of the symptoms, as we had with Sheila this morning, might be indicative of depression.
I felt like a lot of Sheila's answers to some of the questions, her frustrations and the things that made her sad were things that anyone might experience in her situation. Like, how do you differentiate between that and someone who's genuinely depressed?
Right. Well, the tool that we used this morning was just that. It was a tool. It was not diagnostic. So you're right that many of the things that she talked about, you would expect a lot of folks who are older to have frustrations with. The difference is that when a person has to meet the criteria for depression. So do you remember what some of the symptoms of depression were?
Not enjoying activities that she used to enjoy, or just, generally being withdrawn
Right.
from her regular activities.
Right. And concentration issues, appetite issues, sleep issues, subjectively feeling depressed. So some of the questions on this tool might seem repetitive, but sometimes that is because a person might respond better to one question than another question. So yes, to answer your question, that was a long answer, but to answer your question, that was that this is just a screening tool. We would continue to assess her as we did after we did the tool today.
And at what point do you decide, based on her answers to that assessment, that you would need to take some kind of further action or do a further assessment?
When we do the geriatric depression scale, any score that's 5 or above indicates that we need to continue to evaluate for depression. And when we evaluated Sheila this morning, she had a score of 9 out of 15 on the GDS, the geriatric depression scale, which indicates that we do need to do some further assessments with her.
And what would your next step be with her?
The next step would be to either refer her to a psychiatrist or a geriatric clinical nurse specialist or nurse practitioner who specializes in this, or sometimes her primary care provider could continue to do the assessment piece of it. And once it's ascertained that yes, she does meet the criteria for depression, then we would start to talk about treatment options.
What do you do when you're trying to ask these questions and you're just not really getting a lot of feedback from the person? Like, how do you get what you need?
Which happens many times. She was very forthright, and it was easy to sort of connect with her and develop a relationship and talk with her. Sometimes when people are more depressed, and I do think Sheila had a depression, but I have seen people with more severe depressions, they become so withdrawn they don't want to answer any of the questions, and they're not able to answer the questions. So you need to take more time in kind of developing the relationship with them. Some of what I do is look at pictures or try to find some common ground that they have some interest with. Other times people answer the questions but continue to explain what their answers are, and we have to kind of keep redirecting them back to the question because you really do want a yes or a no, which in a couple of the questions that I asked her, she wasn't giving me a yes or no. I had to go back and ask the question again.
Sheila was quite forthright in her answers, but also, like you said, was answering 50-50 to some questions. And then you had to redirect her to try to give you a yes or no based on how she was feeling in the past week. A common response is I don't know from someone who's quite depressed. And she didn't say that at all, but that you'll see a lot. And then again, you can redirect and say, most of the time in the past week, would you say more yes or more no? And redirect them to a yes or a no instead of I don't know or not answering.
I noticed you added some questions of your own, just, I guess, to try to keep her on track.
I did, to keep her on track and also to do a continued assessment. So the tool is one piece of it, and once we suspect that someone does have a depression, then we continue to do the assessment. As I said earlier, when we did the geriatric depression scale on Sheila, she achieved a score of 9 out of 15, which sends red flags up and tells us that there is a good possibility that she does have depression. And in looking over some of the questions that she responded to, which gave her a point, were, have you dropped many of the activities and interests you used to like, which indicates that she has no interest in things that she once enjoyed, which is one of the major symptoms of depression. The other question that she answered yes to was, do you feel like your life is empty? Yes. Many times that looks at like the hopeless, helpless piece of it. She also spoke about feeling like she was a burden to her family members. And that came out when we asked about, do you feel like your situation is hopeless? So again, another symptom that could indicate a depression. The other thing that she answered yes to was, do you feel like you are pretty worthless the way you are now? One of the other things that Sheila said during the assessment this morning was that she felt worse in the morning and better in the afternoon, which many times we see with people who are depressed. It actually has a name. It's called a diurnal variation. And she said that in the mornings used to be her good time, and now they were even her bad time. So I got the sense that she was feeling even more helpless about that. She also spoke about having some thoughts that she would be better off if she weren't living. But what was your sense of that when she said that?
I felt like she was recalling feelings that she had in the past about that,
Right.
but not necessarily that she was thinking about suicide now.
Right. She had what we called more of a passive suicidal wish or passive suicidal thoughts versus active suicidal ideation. So do you remember what we talked about if somebody has active suicidal ideation? And how would that look?
Well, you want to find out if they have a plan.
Right, if they have an intent and they have a plan. And if they have an intent and a plan, we never can leave them by themselves. It's considered an emergency, so we would have to make contacts, keep them on one-to-one, call their primary care doctor, their family members. They could not be left alone at that point. With Sheila's permission, I spoke with her primary care provider today, and he agrees. He hadn't seen her in a while and had not done a depression screening, but based on our findings, he agreed that it did sound like depression. He is coming out today to see her, to visit her. And if he finds, which he thought that he would also, that she does have a major depression, he was going to put her on an antidepressant, put her back on an antidepressant because she's responded to them in the past. So I think at that point, or at this point, we should probably talk a little bit more about her plan of care, about what we should do. So when we talked to Sheila this morning, she talked a little bit about some of the things that she did enjoy. Even though she said she wasn't able to enjoy activities she once did, she could identify things like reading, like the Walkers Club. She enjoyed she told me at one point she goes to the short story club that they have here where they discuss short stories. But it sounds like over the past couple of months, some of those activities have tapered somewhat.
Yeah, she's declined in her ability, her desires to want to pursue the things that she enjoyed most. So part of her care of plan, the plan of care will be to assist her. We do meet with her once a day in the mornings because it's difficult for her when she gets up to start to plan, to organize.
Right, she said her mornings weren't well.
They've been tough for her. They've been a little harder. So we do come in and we give her the support and we give her one choice. We let her pick, but she will keep to the plan. It helps her to have a plan, and she'll partake in one activity a day, such as the reading club. To pursue this even further, when we see her progress, we'll have one of her friends come and pick her up and have her join. Right now she's a little fragile, and it's a little easier for the nursing staff to encourage her. Our goal is to then have the friends come and take her and eventually have her be, as she once was, fairly independent in her choices of personal and social activity.
And that's a really good idea. That's a really good way to approach it. Folks who are depressed oftentimes feel overwhelmed. So if we give them the whole list of activities, they feel like it's too much. They feel like I'm just going back to bed. I can't deal with it. But one thing is manageable. And once they finish it, they also feel like they've accomplished something.
Absolutely.
So it's what we call short attainable goals when we're treating depression. We know that treatment for depression responds best to a medication piece and a talking therapy piece, and the talking therapy piece also involves getting folks involved with other activities. So the medication will have to be evaluated for side effects and also for whether or not she's responding to treatment. But the other piece of it is kind of the environmental piece. What are some other things you can think of that might help her?
I would say one of the things that Sheila would actually do well with is the walking club, which is something that she's very interested in doing. It meets 3 times a week, and if we really work with her slowly, step by step, with the nursing staff to get her involved, getting her in the morning, letting her know where they're going, what to expect beforehand, I think she'll do well with that.
She even said that she likes to go out and talk with people and to find friends and be social, so that can be a great thing for her.
Sheila has a good future to look forward to if we continue with our plan. The medication piece is important. I'm glad the physician's coming out. We will pursue the social aspect, the environmental aspect, taking in consideration the Walkers Club, small limited social groups initially, perhaps pursuing that further as she shows a little bit more independence and less depression. A very, very important, a very huge point to all of this will be to reassess Sheila.
I think one of the things that we were talking about today related to depression, I think Sheila was an excellent example, is that it is a treatable condition in older adults, as it is in younger adults. It's not something to be ignored. It is something to be fully assessed and treated, and in this case, evaluated in a certain amount of time and then reevaluated as needed on that basis. We talked about some wonderful interventions for Sheila, and I think hopefully in her case they'll work. They did last time she had depression, and so we have reason to feel optimistic that this plan will work, and if not, again, you all can reassess as you discussed. But enhancing her quality of life, enhancing her social experiences and interactions with others here, with her friends, with the staff, I think is great. Getting her to a point of being active and requesting different activities down the road when she's able to do more than one at a time is fabulous. Enhancing her physical abilities, her cognitive abilities, keeping her stimulated will help increase her function and enhance her life greatly.
All right. All right, class. Do you have any questions about this? There's a couple points I want to bring out. I hope this made it a little bit more understandable of what we're looking at when we are doing an assessment on our patient for depression. All right. Okay. A couple of things. Notice that just remember that this geriatric depression scale is not a diagnostic tool. Obviously, it is more of a screening procedure, and a score of greater than 5 from those 15 questions really would be suggestive of depression. And it was a really good way of drawing out this patient's concerns about what's going on in her life. It's best not to use the term depression when we are doing this type of assessment. More of, and I kind of like this nurse's way of saying, concerned about your spirit. So that, because telling someone that you're checking them for depression is kind of depressing, actually. So it's not something we want to use. However, just note when they talk about suicide or going to hurt themselves, it's important to remember that if they have a plan and they intend to do something, we never leave those patients alone. That's all part of mental health as well. In the case of our patient on the video, they were going to suggest some type of antidepressant. And there's lots of them. However, some of the nursing guidelines are the things that I want you to be more focused on. And on page 416 and 417, please write that down. You might want to take a look at that for pharmacology as well, actually. But think about for the dosages, remember, because of the older adults change in their physical, the liver function and all of those things, they usually get about half of the recommended adult dose for a younger person because it will affect them immensely. And after a few days, these antidepressants can actually cause sedation. And so then we're thinking about risk, falls. And so we have to kind of keep that in mind. It might take a couple of days. There's some other nursing guidelines here that you need to be aware of. So be sure that you are taking a look at those for next week when you have your exam, but because you need to know that for your NCLEX as well. All right, so any comments or questions about the geriatric depression scale? Very, very important to know. No questions? Okay. All right, just remember that just like with younger adults, this particular condition is treatable. And it's just something to kind of keep in mind for something that we can do with our patient. So as we move on in the mental health, we're talking about suicide risk, and we've already kind of mentioned it in relationship to the geriatric depression scale, but it is definitely a very serious condition for our older population, and particularly with our depressed people. And you notice I have some numbers up here. I'm not going to ask you these numbers, but the suicide rates are highest among older adults, but the baby boomers, their suicide rates have become highest for that middle age, about 19.7% per 100,000, and that's quite high. And those are greater than 85 years old are at about 18.6% suicide rates. And that's significant. As somebody becomes greater than 85 years old, they may have a lot of depression, they may have many medical problems, financial troubles, even worse than they would have as they were going into the age of the old age, life development. And so that's a pretty high number for those over the age of 85. Of course, we do know that males have a higher suicide rate than females. Males tend to use weapons such as guns to commit suicide. Females tend to use pills for suicide. So that's not on your slide, but that's just the information that is important to remember as well. All right. If someone is not getting proper sleep from all the different problems, physical problems, or even those emotional problems, then of course they're at a higher risk for suicide. Any questions about the risk for suicide? All right. Okay, so some of the behaviors, medication misuse, and we've kind of mentioned that where females tend to use medications a lot. Although there are what we call overdoses, even males will use particularly illicit drugs as overdoses, and sometimes it's deliberate. So that's one of the behaviors that might happen. Starving themselves, self-starvation is also another behavior, right? If this healthcare provider has suggested someone not to drive a car, then and they still do it, there could be some type of suicidal tendencies for that. And if they're intoxicated, those types of things could be. I was driving down I-4. Oh, it's been some months ago. And you know, I-4, right before you get to Lee Road, if you know anything about I-4, there's a lot of traffic. We're moving about 60 miles an hour. I was headed into Orlando. All of a sudden, in front of me, some young man was on his bicycle weaving in and out of the 60-mile-an-hour traffic. And of course, we were slowing down because I saw him and I basically almost got slammed in the rear end and he was just moving up and down the I-4. Now, of course, because we were moving and we started to move slower, I don't know what happened to him, but I don't know if he was just trying to get across I-4 on his bicycle or if he had some type of suicidal behaviors, but that's definitely a dangerous place to ride on I-4 with a high rate of speed of the vehicles. And of course, when somebody does have these suicidal behaviors, they can do all kinds of things that could create that problem. I knew a young boy one time who was huffing gasoline, a young teenager, and of course it kind of got his mind kind of messed up, and he was found in his home, and he had taken a gun and he had put it into his mouth and blew the back of his head off. And so how devastating is that to the family? But he had become very depressed, and of course the huffing of gasoline and all those types of chemicals can cause brain changes as well. So suicidal behaviors are prevalent both in the young population as well as in our older population. So let's take a look at which of these clients is at the highest risk for suicide. Is it a 60-year-old with kidney stones, the 85-year-old person whose spouse died about a year ago, a 75-year-old woman who's living with her children, and a 58-year-old who's made an appointment with a primary health care provider? What do you think?
I would say 2.
Okay. Why would you say 2? That you're correct. That is the right answer. So why would you say that?
Well, I was between like 2 and 3, but with 3 because they're living with a child and a grandchild, I feel like they have more social interaction versus with two, I feel like they're more isolated. Um, and a loss of a spouse, in my mind, can also mean they're also losing other people as well because of their older age. So
Hmm.
just that isolation feeling.
Oh, you did a great job of doing those rationales, Emily. So yes, and there have been people you probably know. Perhaps some of you know some people whose spouse has died and they're still extremely depressed a year later. I've heard stories that they can be depressed and miserable for 10 years or more. But again, this older gentleman, because he's already 85 and his wife died and now he's totally alone, that's definitely isolation. With the woman living with her children and grandchildren, I don't think there's going to be a lot of isolation with that, but that could be depressive if she didn't want to live with her family. But you did the correct thing and chose number 2, and that is definitely correct. All right, so we've talked a little bit about depression, we've talked about suicide, and now we're going to talk a little bit about anxiety. I'm sure that in mental health class, as well as in fundamentals, we briefly touched upon anxiety, and of course, I'm sure you got into more great depth in mental health, but it's not uncommon for older adults to have anxiety. And there's all kinds of ways that it's manifested. Sleeping difficulties, pacing, confusion, fantasizing about something that could possibly happen. And of course, restlessness, hostility. That could also be for younger adults as well, or younger people as well. So we know that anxiety has multiple stages. There is mild, moderate, severe, and then there's the panic attacks. And for this class, you don't have to know those, but just understand that anxiety is a major issue as well in our older adults. And of course, with anxiety, the blood pressure goes up, the pulses go up, and of course, which could be detrimental if the patient already has cardiac problems, right? They might play with their utensils and constantly maybe take a towel and wrap it up multiple times and unwrap it and multiple times. So that could also be an obsessive compulsive disorder. However, it can also occur in anxiety. And so sometimes people with anxiety, they really can't focus. All right. So the treatment for anxiety really depends on what's causing it. And there might be some new stressors. So that's why we will do a very comprehensive health assessment on our patients or our clients. And if there's new things like the deaths or financial, or maybe a loss of a job, maybe something's going on with their health that they did not anticipate, and it's bothering them a great deal, and they're very distressed over it. Of course, that can cause anxiety, of course. And we know what happens when we drink a lot of coffee, a lot of caffeine, even nicotine, and some of the medications that we take over the counter can cause an increase in heart rate and cause an increase in anxiety. So there's lots of reasons for anxiety. The treatments for it vary, again, depending on what's going on with the patient. And sometimes they manage without any medications. Maybe if we can manage those stressors, perhaps could be something that would be useful for them. But for nursing interventions for someone who's got anxiety, let's look at a few of these. Of course, if somebody does have anxiety, you want to be sure that you're taking plenty of time, letting them respond to questions, listening carefully to everything that they say, right? We want to encourage them to do as much talking as possible. If they are anxious, say for instance about maybe they have to go for a heart catheterization, well, obviously one of the most important things that we can do is teach that person about what's going to happen, particularly if they already are anxious about that test or that diagnostic. And so preparing them, giving them some information, answering all their questions really helps to reduce that external stimuli which is causing their anxiety. If they're extremely anxious, then of course we don't like to have a lot of people around them because the more noise, the more sound, the more external stimuli, the lights. I'm sorry, that's my phone. I don't know why it went on, but I can't answer it. Sorry. It'll go off in a minute. All of those things are things that we have to kind of focus on, and how can we kind of keep the environment at a very low key relaxation rate as well. And of course, everything needs to be routine. Things around the patient might make them more relaxed. So for instance, if they have pictures of their family and they like those pictures, and make sure that they can bring those into the facility if you're working with them in the facility or even at home. Lots of things that we can do for patients with anxiety. And I've already mentioned about the overstimulation there. Okay. Oh, didn't move. All right, so for substance abuse, of course, as older people get into the later stages and begin to see changes in their life, there is a great more problems with alcohol and other substance abuses. And of course, illicit drugs are used, and even as a middle-aged patient or person, sometimes they just take those drugs with them into their older life as well. And you can see there's a list of the different types of substances, caffeine, even caffeine and alcohol are considered substance abuse. It doesn't have to be illicit drugs or cannabis or any of those things. Right. As I mentioned, the young man that killed himself with the gun earlier, he was using an inhalant. That's what we call huffing, and that's why he really got some anxiety problems and some depression, and he had, that's what caused him to just actually take his own life. So on this slide, we have to really look at our patients, our older patients, because some of the things that we would maybe notice with a younger person for the addiction problems, or if someone is withdrawn, it can be confused with maybe some other type of medical problem. So we have to really notice it, because we may not realize that there's something going on, that they are taking some type of substance. And of course, we're aware of that. So we know that substance abuse can really do a lot of things, not only mentally, but socially and, physically. So substance abuse can be a lot of things, but let's talk about alcohol. Your book brings out alcohol abuse. On page 240 of your book, you might want to write that down. There is a box, possible indications of alcohol abuse. It's a short box, but it's really good. It brings out a lot of things. Some possible indications could be things like blackouts, of course, malnourishment, because someone who abuses alcohol tends to drink more, and so they're not hungry. All right. Maybe they're having some issues at home. Maybe they have that depression. Maybe they've fallen, have a lot of falls. They have GI problems. They get clumsy, but that doesn't necessarily mean they have an alcohol abuse problem. But it could be an indication, because patients that are falling or clumsy, there could be some, particularly our older adults, could be something else age-related that's causing those signs and symptoms. So the criteria for diagnosing alcoholism, it's listed here also on page 420. And basically what it says, it talks about alcoholic blackouts. In other words, a patient drinks so much that they kind of like pass out and they kind of don't remember things. All right, that's one. If they drink a fifth of whiskey a day, or its equivalent, like in wine or beer, and then that's another criteria for diagnosing alcoholism. Any type of withdrawal syndrome, and there in the hospital we have what we call CWA, And this is where we are putting a patient on an alert that they might have an alcohol problem and they might go into delirium tremens simply because they have not had a drink in about 72 hours. That's when we start seeing those tremens or hallucinations. They get a little confused. Sometimes they can get pretty mean. They can convulse. So we are putting our patients on a watch protocol, and I'm sure you've probably seen those out there. And of course, a patient who continues to drink, even though they have, say, cirrhosis of the liver, and they've been told about it, and they should not be drinking anything with that particular condition, maybe they can't stop it. Maybe it's simply because they are a true alcoholic. The treatment, of course, is sobriety, and it's an everyday treatment. It's an everyday having no alcohol. It has to be every day. It's long term. It's a lifetime of no drinking. You don't just stop one day and say, oh, well, I'm never going to drink again. It's rare for that to happen, although I've seen cases where that does happen. But it is a long term no drinking period. And of course, if there's a family member involved, then sometimes that support system is what they need. There are many, many different treatment interventions, of course, AA, Alcoholics Anonymous, are some many treatment programs. And of course, the benzodiazepines are also used. Unfortunately, things like alprazolam, which is Xanax, or clonazepam, which is Klonopin, Librium. Those are some of those benzodiazepines. However, they can become toxic in our older adults. And so they use those to detoxify a patient. So if our patient is older, we really have to pay close attention to whatever benzodiazepines the healthcare provider has ordered. The chlordiazepine peroxide, that's what it's called, is Librium. So be sure you know those three: alprazolam, chlordiazepine peroxide, and clonazepam, which is Xanax, Librium, and Klonopin. This is all those benzos that you have studied in pharmacology and across, I'm sure, mental health as well. So those are important. All right, so let's see about this one. So you have an older adult brought to the emergency department by local law enforcement, and the client was found in an alley next to a tavern, was passed out, and the nurse is conducting an interview with the client. So which statement would the nurse identify as indicative of an alcohol use disorder? In this case, it's a select all that apply. So take a look at that, and what do you think? Remember, this type of question doesn't mean that we are diagnosing our patient, but we are looking at things that could potentially indicate that there's an alcohol use disorder. So who would like to take that one?
I can try.
Sure. Thank you. Go ahead. Yes. Who is this? I didn't see your face.
Mira.
Okay, Mira, thank you.
I think maybe number one, sometimes I drink a bottle of whiskey or more each day.
Okay.
And then number three, my doctors tell me to stop drinking, but I am fine.
Okay.
And five, I have had some tremors when I stopped drinking.
Okay, so you're saying 1, 3, and 5?
Yes, I'm not sure about number two.
Okay.
I don't think it's number two.
Okay. So let's take a look. Okay. So that is your answers. Oh, sorry. Okay. All right. So 1, 2, 3, and 4. In the criteria for diagnosing alcoholism, and of course I didn't mention this, but it's in that little box on page 420. The blood alcohol level greater than 150 milligrams per 100 meals is one of those diagnostics that they use. So it's greater than 150 per 100 meals. Now, the patient who says, I've never had any episodes of blacking out is, they would black out, but if the patient says they haven't had any, you have to take them at face value, right? Because there's no proof. So that one really would not be indicative. They say they've never had any. Okay, so you would not want that one. The others are definitely some of those indications for potential alcohol use disorder. Right, really good. Right. So overall, for mental conditions, definitely going to monitor the medications. But many of our medications, as you know from our polypharmacy discussions and your pharmacology and all those things that you've learned, we know that medications have many side effects and some have lots of adverse effects. So it is important to know your meds and to know what are some of those side effects and how can we handle those particular meds if the patient is on it. And if there is an adverse effect, how would you recognize it? If you have a medication that can cause anemia, obviously you're going to look at the H&H to see, and you'll look at the skin color and the sclera, all of those things for identifying if there's any adverse effects for that particular patient and that particular drug. So monitoring your medications is definitely important. We always want to make our patients feel comfortable with us, with themselves. So we do a lot of interventions for them. We like to do those life reviews, encouraging them if they'd like to do scrapbooking. We as nurses definitely need to take interest in their lives. And particularly if you're working in a clinic or a home health situation, you get to know your patients, like the nurses and the student nurses in our video today, working with that patient. They seem to know her. They go out there because they're home health, obviously. And so we want our patients to be working with others, being active, having things that they can do. That's, it's all about positive self-concept. And so that's part of what we do. Now, how do you handle some behaviors? This is a truly an important table. I put it on here for you. It's understanding and managing common behavioral problems. Please make sure that you're looking at this. Okay, for instance, I'm not going to read all this to you. You can just go through it, and many of these you already know from your past, but I definitely would take a look. So for instance, if somebody is resisting care, that's one of the behaviors. They don't want anybody to help them. There's a lot of causes for that. It could be depression, it could be dementia, or maybe not understanding what the nurse is trying to do. So what you want to do, first of all, you want to make sure that you just monitor them, making sure that you break the activities into simple steps. Be sure that you're doing a lot of explanation. Remember to go slow with these patients because that anxiety will only increase, particularly with dementia. We never argue with them, those types of things. So be sure that you are taking a look at table 29.3 in your textbook. It's excellent as a discussion for how do we manage those problems. There are many causes of these types of behaviors, but always remember in your NCLEX as well as in your nursing career, assessment is always the first step. And so whatever behaviors that you see in your patient, these are things that you think about. The time of onset, where did it occur, who was around when these behaviors began. I mean, these are things that you can use for almost any type of assessment. It's not so much for behavioral, for just the older person, but we can use these kinds of questions to ask your patient, such as symptoms and signs and symptoms. What did that person do to help or worsen the problem? And so we always need to try to assess the cause of those unusual behaviors that they're having if there's possible. So these are just some suggestions on how to do it. And of course, I've already mentioned some of these reducing the behavioral issues. We've talked a lot about the calm and quiet environment. If somebody is compulsive or doing something that's inappropriate, many times we need to distract them with some other activity. Safety devices is always an important piece as well. Of course, hygiene, taking care of them, and making sure they can go to the bathroom when they need to. These are just some reducing some of those behavioral issues that we do find in patients with mental health disorders, anxiety, depression, and even substance abuse or alcohol abuse. All right, so this chapter is finished. We talked about those three major categories, how to assess it. We've looked at the geriatric depression scale and how to manage some of those unusual behaviors that we might see. So does anybody have any question about substance abuse or mental health disorders? Okay, no questions? All right. Okay, so what we're going to do, we're going to take our break. It's 11:14. We came back at 11:15, so I want you to have another break. All right, so I'm going to give you a 15-minute break to kind of stand up and stretch. And because when we come back, we're going to talk about comfort and pain management. And there's quite a bit of information that I want you to know from that particular chapter. Quite a bit you have been exposed to in nursing school, but there's some things that I'm definitely going to be pointing out to you. And we will also watch a video on assessing pain in our older adults, because remember, with older adults, their threshold of pain goes up. So they might have lots of pain, but they can handle it. So you don't know for sure if that 4 on that 0 to 10 scale really means that they're in pain, or are they in much higher amounts of pain because their threshold is so high. So again, we're going to look at that when we return. I'll see you back here at 11:30. And thanks. I'll be back. All right.